Hello, and thank you for checking out FirstcallID, Approach to Central Nervous System Infections. My name is Paul Bunce. I'm a specialist in adult infectious diseases and internal medicine. We'll be spending the next 10 to 15 minutes going over some of the key aspects of an ID consultation. If you haven't done so already, please check out our first session on how to do an infectious diseases consultation, which covers a lot of the basics of ID consultations in general, whereas this session is really focused on the specifics of central nervous system infections in adults. Now, while there's overlap in how we evaluate different central nervous system infections and inflammatory process, such as meningitis, encephalitis, or abscess, this session is really focused on community-associated presentations. A separate session will tackle the nosocomial post-neurosurgical domain, because these cases have some specific variations in terms of the pathogens, the prosthetic material that's involved, and some surgical nuance. Lastly, before we move forward, just a quick note that this content is for educational purposes only. Please refer to current guidelines and use professional judgment in your practice. So before we get into the details, just to start with, when should we actually suspect a central nervous system infection? And there are no absolute rules, but there are some clues. The first is acute or subacute neurologic symptoms, including but not limited to fever, headache, altered mental status, and focal neurologic deficits. Often for me, it's a patient presents with fever, headache, or any neurologic symptoms, and no other explanation beyond possible CNS infection. Patients who present with signs of meningeal irritation, such as neck stiffness, photophobia. Patients with new onset seizures or unexplained encephalopathy. Patients who have an immunocompromised state or relevant exposures don't necessarily have CNS infections at the top of the list, but these need to be considered as these patients are at higher risk. Patients who have a lumbar puncture or CSF analysis for another reason, but show abnormalities or suggestive imaging that could suggest a CNS infectious process. Or any recent, or even not so recent, CNS surgery or procedures. This is a drawing made by my colleague close to 15 years ago when we were talking about a presentation for CNS infections, specifically brain abscesses. And we wanted to cover the mechanisms for infection, and so she shared this with me for this talk. And although it's somewhat basic in its detail, I think it is illustrative. So when you think about CNS infections, especially pyogenic infections or bacterial infections, the mechanisms include those from the sinuses, both frontal and maxillary, dental sources, autogenic sources from the ear or inner ear, nosocomial infections due to instrumentation or trauma, that's why I put a drill, and infections that spread hematogenously for any number of reasons. Now, one of the most important parts of this talk, and something I've said before, is the essential need to define the syndrome. So what is the patient actually presenting with? Because when you're able to define the syndrome, it can allow us to work on a differential diagnosis and come up with some empiric therapy options. So is this patient presenting with meningitis, encephalitis, or a mass lesion or potential brain abscess? And there is occasionally some overlap between these, and so it's somewhat arbitrary to separate them, but it's important to think about what the primary problem is. So meningitis, or inflammation of the meninges, typically presenting with fever, headache, neck stiffness, abnormal CSF parameters. Encephalitis is inflammation of the brain parenchyma, where patients usually present with altered mental status, maybe with seizures or focal neurologic deficits. Whereas a brain abscess or a mass lesion presents with a focal intracerebral collection or mass that can be pus or other inflammatory material that can be caused by infection or other processes. And in these cases, the context really matters as well. So the chronicity, is this an acute process within hours? Is this subacute within days to weeks, or has this been going on for weeks to months? We want to specifically identify any immune modifiers, either immunosuppression or immunocompromising states. And we want to pay attention to epidemiology and exposures, especially with cases of encephalitis, because sometimes the epidemiology is the key or the main clue to what's explaining or the underlying process. So the key points to our assessment. So we want to characterize the symptoms and the clinical course. We want to highlight exposures and epidemiology. We want to get a clear medical history, our physical examination, including a detailed neurologic examination. We'll highlight our initial investigations, and from this we'll come up with our impression and recommendations for further evaluation and management. So first, we characterize the symptoms in the course. So classic symptoms of CNS infections, so fever, headache, focal neurologic deficits, alterations in level of consciousness or executive function, or seizure, We do a full general review of symptoms or systems to see if there's anything systemically that could explain a CNS process. We also want to understand what's their management to date. Have they had any interventions, received any therapies that could have improved their situation or altered their course? Again, we'll pay key attention to the exposures in epidemiology. So in cases of encephalitis especially, what is the season? What is the patient's locale? Where are they living and where have they traveled? Occupation, recreation, and other potential exposures to different types of pathogens. We'll also inquire about substance use and sexual exposures. And I'll highlight that the epidemiology in a lot of cases can be actually more helpful than the specific exposures. So for example, if a patient has traveled or lived in a Lyme endemic region, to me that's more relevant than whether they recall having a tick bite. Okay, so it's really important to get a sense of the epidemiology, more so sometimes than the specific exposures. We'll want to get a detailed medical history. As I mentioned before, we want to be aware of any immunosuppression that they've received either currently or previously, or any immunocompromising state. A history of prior malignancy is important to understand and recognize, as well as the particular therapies that they've received in the past. So is there potential for metastatic disease, CNS complications of cancer treatments, maybe immune dysregulation that again can persist for some extended period after it's been administered. If there's been any medical intervention, I like to highlight any neurosurgical procedures, which could encompass not just neurosurgery, but also anything that could disrupt the meninges or cause perimeningeal inflammation that could lead to a CNS inflammatory or infectious process. And also, if there has been any surgical procedure, is there any retained instrumentation or prosthetic material that could act as a nidus of infection or a focus for less virulent pathogens to still play a role and persist? So as always, a complete physical examination is indicated. We're focused on the general parameters, vital signs as well, level of consciousness, any signs of severe illness or instability. Our neurologic examination is a bit more detailed than we would typically proceed with. We'll assess the mental status and, if necessary, motor, sensory, and coordination testing. We'll specifically address the presence or absence of nuchal rigidity or jolt accentuation if a headache is present. And with the neurologic examination, it's something you'll pay attention to not just when you're thinking about doing a neuro exam, but throughout your assessment. I think about patients I've seen where throughout the assessment we could see variations in their mental status or cognition, also patients who've had complex partial seizures in the middle of an assessment that we might not have noticed if we weren't paying attention to it through that period of time. Our general examination will include an evaluation of the oral pharynx for any poor dentition, evidence of immunocompromise, lymphadenopathy, a routine chest examination, cardiovascular examination, thinking about things like endocarditis, an abdominal examination and musculoskeletal examination as well. Also, a dermatologic examination is something worth highlighting. It's never unremarkable, but it's notable whether the patient does or does not have a rash, stigmata of endovascular infection, or any specific skin manifestations, such as something called purpura fulminans, which you can see in patients with meningococcemia. The investigations we look for include general investigations, so routine blood work, and any microbiological tests that have already been sent, often routine blood cultures, and maybe some other things as well. Imaging is necessary for the evaluation of patients with CNS infections or potential CNS infections, which usually starts with a computed tomography or CT of the head, and often followed by an MRI, which can look for different types of processes, and they often go hand in hand in terms of highlighting different problems. In patients where you're worried or suspecting systemic processes that are affecting the CNS, other imaging can be helpful, such as chest imaging, like a CT scan, sometimes abdominal imaging, or even an echocardiogram. From a microbiological perspective, again, blood cultures are often indicated in patients who are febrile, systemically unwell. CSF analysis is crucial for many of these inflammatory processes, and I'll speak a bit more about that later. And serologic testing can also play a role depending on the presentation. So things you might consider early on, HIV serology, the potentially syphilis serology, Lyme disease serology if they've been in an endemic region. Depending on the time of year, different types of arthropod-borne viruses or arboviruses, including West Nile virus. And any other non-infectious serology. Usually I'll do this in conjunction with one of the other specialties involved, such as neurology or maybe even rheumatology or internal medicine. A few words about a lumbar puncture and when it's necessary and when it's indicated. So for me, the indications for a lumbar puncture when there's a suspected CNS infection, such as meningitis or encephalitis, not necessarily for a brain abscess. It's also for the evaluation of other considerations, such as malignancy, inflammatory processes, or demyelinating diseases. Contraindications to LP, there are lists that you'll look up when you're going to perform an LP, but to me, the general one is when it's not safe to perform an LP. Some examples would be an elevated intracranial pressure, evidence of coagulopathy, certain patient factors, including whether there's not a safe position to do the procedure, the environment, the patient's behavior or mental status, if they're not able to cooperate fully with the procedure so that it's not safe, or if they're hemodynamically or neurologically unstable, it might not be the best time to perform a lumbar puncture. And then clinician factors, comfort of the clinician in terms of doing an LP, and also the situation, and you balance this with the urgency. So if you're in the middle of a call shift managing a number of patients, maybe being gowned up and performing an LP might not be the safest thing for you at that moment, but that has to be balanced against the need for an urgency of a lumbar puncture in that patient. In terms of what to send, I've actually had phone calls on call at night by different clinicians saying, we're worried about a CNS infection. What should we send the fluid for? And I almost always give the same answer. So you send it for the routine studies. So cell count with a differential, glucose, protein, gram stain, and bacterial culture. And that's the main thing. And then what I say is, and then take any fluid that you have left and send that to the microlab to save for later. And so there's some additional microbiology you might ask for upfront. Some institutions will automatically trigger or reflex a multiplex PCR for different types of bacterial or viral or even fungal pathogens. Sometimes we'll ask specifically for viral PCR for herpes simplex or varicella zoster. Cryptococcal antigen might be sent. And then in some specific situations, and often not on the first LP or at least initially, things like acid-fast bacilli or fungal testing as well. Cytology can be requested. It's important to note that cytology is often only processed on weekdays during the daytime. And so if you're performing a lumbar puncture on a Friday evening, there's a chance that that might not make it to the cytology or pathology lab until Monday where the cells have degenerated. And so if you are worried about malignancy, then maybe it's better to perform or delay the LP until a weekday, or recognize that you might need to do a second LP later on in the course, which is not unheard of for a lot of conditions. And then there's some other tests that might be requested as well. For me, usually those are done at the request of other colleagues or specialists, including neurologists. So from this information, we'll provide our impression and recommendations. As I've said, the key thing is to characterize the syndrome. So what is the syndrome? Is this presenting as an encephalitis, a meningitis, maybe an overlap, or a CNS mass lesion or presumed abscess? How severe or sick is the patient? What is the chronicity? Is this acute or chronic? And are there any immune modifiers that may alter our potential pathogens in this case? And also highlighting any prior interventions or neurosurgical procedures. And so if you're able to use this, you can actually define the syndrome quite well and be able to come up with an initial management plan or recommendations, or be able to look it up. At this point, we'll highlight the need or value of additional investigations when safe to do so. So if not yet available, is there a role for CSF evaluation or repeat lumbar puncture, or any other invasive testing, procedures, or imaging? If we're concerned about transmissible organisms or infections, we can advise on isolation. We can advise on empiric therapy, again, based on usually local guidelines, and if not, other more broadly published guidelines based on the presenting syndrome, and whether there's a need for any additional consultations. We'll also provide a preliminary plan or opinion about what can be anticipated or the anticipated course for the patient. For me, this is most important in patients who present with encephalitis. And the point is that a large proportion of patients who present with encephalitis will not get a clear or confirmed diagnosis during their admission. Right? So a large proportion end up undiagnosed. And it's important to emphasize that our job is to work to come up with a diagnosis, but also to support the patient and their body and their brain during this acute phase to hopefully allow them to recover if we don't identify a cause. Lastly, some additional pearls. Just recognize that all presentations suggestive of CNS infections have a number of non-infectious considerations or counterparts on the differential diagnosis. And there's lots of examples of this. I've seen a handful of them over the years. And it's important to know that even though infections could be a cause, that there are other things to consider. We may treat for infection up front while we're starting the process, but know that there might be other things to consider. We don't want to get pigeonholed or tunnel vision into the infectious pathway. The other thing is that aside from the rare case that is clear or straightforward, where you have a clear diagnosis or management plan, anticipate collaboration with your colleagues, and they could include medicine, neurology, neurosurgery, medical imaging, and microbiology, to name a few. I think it's really helpful to collaborate with these individuals and these colleagues. I think that when some of these challenging cases come up, it's really important that we do communicate regularly with these specialists so that we're not working sort of asynchronously or also almost contrary to each other. When you send CSF to the lab, there's a limited amount there, and every test that's ordered costs like a half a cc. And so when you're both working to sort of come up with different tests to be sent, you need to work together to decide and prioritize what are the most important tests to send and in what order. So just again to review the key points, when we see patients with potential CNS infections, we want to characterize their symptoms and their course, define the syndrome. We want to pay attention to exposures and potential epidemiological links. We'll get a clear medical history in terms of other comorbidities or predisposing conditions, a detailed physical examination including a thorough neurologic examination. That's not just a snap in the moment, but also observation of their mental status. We'll look into the key investigations, and from this we'll provide our impression and our recommendations for management and further evaluation. It's hard to come up with key references when we have such a broad topic, but here are some very helpful ones that I found that are just nice overall reviews to these various syndromes. So Progress and Challenges in Bacterial Meningitis, a review from JAMA, very helpful review. And then 2 New England Journal of Medicine articles, Acute Viral Encephalitis and Brain Abscess. All of these I think are very helpful in terms of references. The other thing is when you are looking at some of these particular syndromes, UpToDate can actually be quite helpful in terms of looking at the evaluation and management of syndromes when you're able to define them. They also provide very thorough or comprehensive tables of potential causes, which aren't really a checklist for you to tick off every particular one, but at least gives you a list of things to consider when you are evaluating these patients. So that's all for now. I'm Dr. Paul Bunce. I want to thank you again for watching. Please share any feedback you have about the session or First Call ID as a whole. And if you like what we're doing, you find this useful, tell a friend or share with your trainees.